Thank you.
Right.
So, first of all, may I acknowledge the traditional owners of this land. And in fact, what I'll do is I will take your acknowledgement that I'm sure you or Adrian gave at the beginning of this meeting, and just let you know that I'm on Wurundjeri land right now at the moment at the Alfred Hospital. These are my disclosures. During the past 3 years, Gilead Sciences and Vive Healthcare paid monies to the Alfred Hospital for me to work in educational events or do research that was funded by those two pharmaceutical companies listed there. And today, basically, I'll talk to you about factors that influence the neurocognitive health in aging people living with HIV. And as I mentioned, we'll talk about HIV specifically, and then look at other very important factors that may either add on top of what HIV can do, or may even plausibly interact with HIV, so they could synergize their impact on the brain rather than just having additive effects. So this is a slide which formally tells us about the nomenclature for how to talk about HIV-associated neurocognitive disorders. So in a study that Dr. Mark Block did with Bruce Brew and Lucette up in his clinic in central Sydney, where the vast majority of the people they enrolled were virologically suppressed, they assessed their cognitive health. And they found that about 15% of patients were people who what we call have asymptomatic neurocognitive impairment, meaning no symptoms, as it's stated. But when you formally tested them on neuropsychological testing, they did have impairments in 2 different domains in the brain. So we have domains of memory, attention, concentration, motor skills. There's all different parts of the or connections and areas of the brain that are responsible for different aspects of the way our mind works. So if you had impairment in 2 of those domains that were 1 standard deviation or more below what the average is for people not living with HIV who are the same age and the same sex and have the same education, then about 15% of them had asymptomatic impairment. Then about 13% had symptomatic impairment, but it was mild. They had mild symptoms with cognitive problems, but they were still working and active. And the definition of impairment is the same there as asymptomatic. And fortunately, only 3% were officially thought to be or met the definition of dementia, meaning that there was significant impairment in their activities of daily living, and they had more severe impairment in 2 or more domains, which were 2 or more standard deviations below what the matched HIV negative controls would be. So they really were in trouble, those patients. And you have to make this diagnosis, you have to be really quite strict. The person can't be delirious, they can't have a major active depression, they can't have just had a head injury, they can't be using large amounts of opioids or methamphetamines. It would be very hard to be completely sure that all the changes that would be present in populations with these confounding effects were to do with HIV, and I'll come back to that later. And I just wanted to make a note here that there is evidence that people with asymptomatic impairment are likelier to go on and get symptomatic impairment. And there's a small risk that those with mild symptomatic impairment could go on to get dementia, HIV dementia, but it's very low, thankfully. When you look around the world at cohort studies, which essentially, and most of the results are cross-sectional, you can go to Bangkok, Geneva, Sydney, and many cities in the United States and look at outpatient clinics and determine what proportion of the HIV positive people in these clinics who are on treatment and virologically suppressed might have one of those disorders, asymptomatic neurocognitive impairment, or symptomatic, or dementia. And the answer is about 30%. So this is the world around us today. That's the proportion, and in some settings, even higher, 40 to 50%. But the average across many very good studies is about 30%, predominantly asymptomatic impairment and minor neurocognitive disorder. So here, and again, forgive me if I'm sure many of you know all about this, but in terms, this is a synopsis of what happens. We'll discuss clinical features, how the HIV affects the brain, the areas of the brain that are affected, how you work out or how you determine whether this is HIV and how you treat it. So this slide talks about what are risk factors for developing cognitive impairment. And I think the two most important are your nadir. How low was your CD4 cell count ever? Like if it was under 200 or under 300, that probably increases your risk of HIV dementia in the future. And also there's evidence that your current CD4 cell count, if it's low, even if you're on treatment, may put you at risk of dementia. And other things like being much older at the time that you acquire HIV, we see a higher proportion of HIV dementia in those patients. And I won't keep going through that. I just wanted to largely emphasize CD4 cell counts. Prior to triple therapy, when there was no really good therapy whatsoever, about 20% of people with advanced untreated HIV, that means CD4 cells under 200, no treatment, about 20% would develop the full dementia picture. So it was very prevalent prior to treatment. So it's sometimes we see patients present to hospital, maybe 1 or 2 each year, with typical HIV dementia, really symptomatic, that's affected their lives. And they're often people who are undiagnosed with HIV and they present with HIV and an AIDS illness all in one go. So today we might see, as I said, 1 or 2, and those people will come in very slow in their motor movements. They have difficulty going heel to toe, walking in a straight line. They might have difficulty with fine movements like doing up their buttons or writing something small on a piece of paper. Occasionally they have a fine tremor. When you examine these patients, there's not usually a lot to find, but it's about slowing down. If you think about Parkinson's disease, it's not dissimilar. It's actually a similar area of the brain where not a lot of movement on the face. They're slow in their speaking, they're slow in their thinking, but they're not, they are aware of the date, they know what year it is. They're not like people with Alzheimer's disease who become completely lost to time, place, and person. Essentially, the virus, this really wretched virus, is able to probably almost in all people during seroconversion enter the brain and infect brain cells. And in a proportion of people, that infection is durable and remains there. Can be quiescent in a number of the brain cells, the macrophages and microglial cells. Prior to what we used to say triple therapy, or prior to a very comprehensive, effective combination therapy, one could actually look down the microscope on a brain biopsy and see inflammation and lots of immune cells gathered together in the brain. It was a very inflammatory process in many patients. But in the modern era of virological suppression, that sort of very active, prominent neuropathology is not really seen anymore. This is a really important slide, and I think it will be of interest to you guys, which is that it's a diagnosis of exclusion to exclude to say confidently that a person has the symptoms they have are a result of HIV. You have to rule out other things like active depression or psychosis, diabetes, uncontrolled diabetes, thyroid disease, previous heart attacks or strokes. Low testosterone can cause cognitive changes in men. Neurosyphilis, I just saw a case recently who had marvelous return of cognitive function with treatment, active substance use. So you have to sort of rule all those things out. You couldn't confidently say, yep, this is HIV causing your problems, and you'd have to go away and treat these other confounding conditions. So you take a detailed history, you refer the patient for neuropsychological testing, which is actually the clincher, and that's shown here where you administer over 2.5 to 3 hours, and some of you may have even had these tests, a number of different tests which will test out in a very sensible, organized fashion a person's memory, short-term and long-term memory, their attention, their ability to stay on track with a complex task, their executive function, how quickly they can move from one task to another, their fine motor skills, their verbal learning, how well they can learn a list of words, their ability to construct visual diagrams. So it's quite exhaustive, but it's really the pinnacle of, and the most important thing I turn to, apart from the history is important, but if a neuropsychologist has seen a patient and done this exhaustive examination and said, I think these features are so-and-so, so-and-so, and they're the typical ones we see in HIV, then that is a very important piece of information. Doing an MRI scan of the brain can be helpful, but is often not of great importance, won't seal or clinch a diagnosis. It can be completely normal. And in some patients, we go on, once we've found the neuropsych report, and if we've never met them before and these symptoms have only come on, say, in the last 6 or 12 months, and it's getting worse, we would actually go on to do a lumbar puncture to look for active CSF infection coming from the brain, even if their plasma viral load was undetectable, and I'll talk about that later. In terms of treatment, I'll be brief here because the area is a little contentious still. Of course, we treat people with combination antiretroviral therapy, and the great news is that at least, in my experience, certainly more than 50% of patients, at least 50% of patients show marked improvement, which can continue out to at least 18 months. So it's really one of the only sort of actively treatable dementias in the world. And that's always been the good news that always gave me a lot of, heart and kept me going, knowing that you could treat people and they'd get better. What you treat them with is what's contentious. Do you need to give people treatment where the drugs you use have a very heightened capacity to get into the central nervous system and at very good levels so that they can treat the infected cells within the brain? There's expert opinion suggests yes, and I must say that Bruce Brew in Sydney, who's my mentor, supervised my PhD in this area, and I both feel that the literature, because the studies that have been done to investigate this have very small, essentially pretty small numbers, and confounded by a lot of things, we kind of expert opinion think you probably should. But the data are definitely equivocal, and a lot of the international guidelines do not recommend using that you need to use treatment where the drugs are known to get into the brain very well. So why might we have 30% of people still, despite spending 2+ decades or more on antiretroviral therapy, dutifully taking those tablets every day, like doing such an amazing job, why are they subject to having such a high proportion of cognitive problems? So it might be that it's hand, what I've put here, and or that it's hand either plus other factors such as those listed there, or hand synergized, worsened with, even worse with these other factors that I've listed here. So I think we go on to here. So I just wanted, so legacy effect is when a person, they're HIV positive, they get diagnosed, they haven't been on treatment, their immune system is suppressed, they may have already experienced a cognitive insult from HIV virus. You start them on treatment and they never really recover fully from that original cognitive insult. That's known as the legacy effect. And then poor CNS HIV viral control, or CSF escape, you guys might know it better as by now, is when you do a lumbar puncture and their viral load is detectable in the CSF, but not in the plasma. And then the next one is there ongoing CNS infection in the brain? Now, in patients, we can do a CSF if we're worried about HIV cognitive impairment, and the CSF viral load is less than 20 copies per mil. But maybe at a tissue level, in fact, the evidence does show that there is ongoing viral replication in brain tissue, and that can lead to inflammation and bring the immune system in and cause activation of the local immune system and the peripheral immune system that may end up damaging the neurons, the support structure of the brain, the cells that support the brain, the oligodendrocytes, And a lot of those those cells are deep in the brain, but also around the blood vessels. So those are some possible explanations there. And then other factors, because as John said, we're always changing, we're going through time. We may have cardiovascular risk factors, such as poor kidney function, diabetes, hypertension, which are all associated with having a high body mass index or being overweight, to put it bluntly, which are associated, especially in midlife, with future risk for vascular dementia. Just the effect of aging itself. Does HIV accelerate the effect of aging in the brain? Could some of these long-term treatments themselves be responsible for people becoming impaired in over time? We'll address that. Is it that some people are developing Alzheimer's disease, perhaps, or Parkinson's disease? We do see that in this population. And also, what is the role of depression? Could HIV predispose to depression, and sort of vice versa? Could depression predispose to HIV impairment? So in terms of the legacy effect, it's a risk when you meet a person for the first time. You don't know them well, they've never had neuropsych testing before. If you just say, yeah, that's probably from the past and you're okay now, that would be an error. What you would do there is follow that person up over time and probably investigate them with a lumbar puncture. It may explain some of the problem, and if they have had prior injury to the brain and it's stable and not getting worse. In a recent paper from Bruce Brew, he, the doyen really, he and Lucette Cizik postulate about the risk of having taken the brain's reservoir, made it smaller because you've already damaged it, so that the capacity of the brain might be diminished. Is it CSF escape? Remember, I said the plasma viral load's undetectable, but lo and behold, you do a viral load on the CSF and it's positive. It's really uncommon. In the clinic that I run, it's probably 5% of the patients or less. And in all the international literature, it's around 5 to 10% of patients. And these are people who start to go off. They can get headaches, they could be confused acutely, or they might just really become forgetful and slow down and run into trouble with managing their activities of daily living. And we'll talk about how to treat them in a moment. And then I mentioned ongoing CNS parenchymal, CNS, in other words, brain tissue infection and inflammation. And there are some data, one small study, again, from Bruce Brew, where he treated patients with Maraviroc. He added it into their current regimen and they had improvement in their cognition. And another study that came out called the Neuro 3 Plus study a couple of years ago, showing that people with HIV-associated neurocognitive dementia or disorder, they actually switched about 30 plus patients to a much higher a regimen, which clearly had drugs in it that got well into the brain, and they had significant improvement in their neurocognitive test results. So, the idea there is that you probably, in some cases, you really should think about intensifying the regimen or switching the regimen. And as I alluded to before, neurocognitive performance goes down for anyone who's suffering from things like diabetes, high blood pressure, kidney failure, high lipids that are untreated. These are all associated with insults to the brain and may be happening simultaneously in a person living with HIV and may not be being well managed and identified well. And this, we might discuss some fantastic work that I know John Rule and Napwa and Lucette Cizik and others have been involved in some wonderful activism around trying to improve surveillance and evaluation of dementia risk factors, such as cardiovascular risk factors. In terms of aging, it's a bit like should you treat HIV dementia? And there are variable findings from many different studies that have tried to figure out, does the brain age more rapidly if you're a person living with HIV? Some studies say that there is evidence, and some studies say that there is not. One big study from America a couple of years ago suggested that it's actually in older people, in older people, that it's more so-called comorbidities, diabetes, hypertension, vascular disease, that seem to be driving dementia, whereas in Australia, Lucette and Bruce's work suggests that there may well be that the brain is aging faster than it should be because you're living with HIV. So that the jury is out on that. I mentioned combination therapy could be toxic. You can look at animal models and cell culture models, and we know as clinicians in the community that some drugs are absolutely wretched. That, for example, efavirenz cause lots of neuropsychiatric side effects. The early integrase inhibitors, raltegravir and dolutegravir, were both associated with CNS toxicity, severe insomnia, especially in women, depression. And let me just check this. Yeah, this schematic here, which is trying to schematically show what might happen to some people who are on treatment for too long. So they start out with a high viral load. They start antiretroviral therapy here. The viral load goes down. At the time they start antiretroviral therapy, maybe their cognitive function isn't so good. And thankfully, as the viral load comes down and time passes, as a cohort or a population, people's cognitive function gets better and continues to get better out here. But there's an argument that maybe some people, about 20%, over time actually get worse. And the hypothesis is it because the drugs, especially protease inhibitors, which get into the brain in very high concentrations, maybe they are actually toxic to the brain cells. Nearly finished. And I mentioned concerns, what neurodegeneration, it's a type of dementia, and neurodegenerative process is one where a person begins to actually develop a dementia with severe memory impairment, and or motor impairment, and that's like Alzheimer's disease and Parkinson's disease. And there are a number of case reports and different cohorts where there is some concern that we're seeing these two types of dementia, or one type of dementia and Parkinson's disease, which can be associated with dementia, a bit in younger people living with HIV, younger than you would normally expect to see it in people who are not living with it, who don't have HIV. But however, when you sort of look at neuropsychological test results and brain imaging results, that isn't yet borne out. And it sounds anecdotal. I have only seen one or two people with Alzheimer's type disease over many years living with HIV in the clinic. But it's something that one must look for nonetheless. And the neuropsychological testing does a very, very good job of sorting out Alzheimer's disease, in a sense, from HIV dementia, because people perform very differently on the neuropsychological tests with those two different conditions. And finally, I just wanted to mention depression. Depression is certainly, people living with HIV have a much higher risk of depression than people in the general community, and it's underdiagnosed and undertreated in people living with HIV. Interestingly, people with depression have inflammation in their peripheral blood. You can measure higher levels of inflammatory cytokines in people with depression. And also within the brain, there's, as I understand, sort of less dopamine, less opportunity for dopamine expression and in neuronal synapses, and shrinkage of neurons. And as it turns out, the type of inflammation that is promoted because of HIV happening in the brain, that inflammation brought about by HIV in the brain welcomes in and promotes the sorts of brain changes that you see in people who have depression. So whether or not the relationship between the importance of depression and HAND hasn't yet been fully elucidated, but I must say, in the general population, and it's very disturbing, the big long-term cohort studies are showing that the broader population, anyone with a major depressive illness, has a significantly higher risk of dementia in the future for whatever reasons. So if you were forced to answer the question, what do you think the key reasons are for why we're seeing at least 30% of our people who are virologically suppressed having cognitive impairment? It's probably the reasons shown here kind of in pink and the widest here in red. Maybe, I think less drug toxicity, but aging, cardiovascular risk factors, I think that's a really big one, and ongoing parenchymal low-level infection in some patients. So what can we do for the legacy effect? If you, with that legacy effect, you investigate the patient, they're stable, their CSF's fine, you're not too worried about them, you get them back and you repeat that neuropsych test and make sure it is stable. If they do have CSF escape in the central nervous system, then you would switch, our practice would be to switch them to a different regimen with good penetration into the brain. If you suspect that you can't find HIV in the CSF, but maybe the CSF neopterin level, which we also measure as a marker of inflammation, if that's elevated, you might actually add Maraviroc or switch the regimen or just observe them and repeat the neuropsych in 6 months to see if they're deteriorating. It's very much a kind of an art form and a case-by-case approach, I have to say. With cardiovascular risk factors, they have to be identified, and we have to try and support patients to take medications to help them with their lifestyle, exercise, diet. And many people can't do that because they are poor. They may not live close. It may not be easy to get out and walk. It may not be safe to get out and walk, or they're frail and they can't. So it's actually a big ask to try and optimize cardiovascular risk factors, but it's important. Not much we can do about aging, but we can try and optimize exercise, diet, sleep, decrease alcohol use. With CART toxicity, if a person's really deteriorated and they've switched their regimen recently, and occasionally you do see this. 3 months ago, they switched to a new regimen and they're depressed and they're irritable, then that might be the actual cause of their cognitive problems, and you can put them on a different regimen and see how they go. If you're concerned that a person, even if they're in their 50s, might have dementia, or in their 40s might have Parkinson's disease, as I say to people, believe your eyes. Like it says, it looks like Parkinson's, they've got a tremor, they're stiff, they're not walking properly. Don't think, nah, it can't be right, they're too young. I'm sort of kind of almost talking to doctors in this sense, or clinical healthcare workers, but also to you guys too, because you might have friends who have symptoms and they look just like Parkinson's, or their memory's really gone off, but they're not too old. Believe your eyes, investigate accordingly, and treat depression accordingly. And I'll leave it there and say thank you for your attention.